Okay, so a summary of what we will cover today. I'm going to give you an introduction to IRISi because although most of you, I think, are from the network and involved in roles either to do with the IRIS programme or the ADVISE programme, there are some unfamiliar names. So we'll cover what we do at IRISi. We will talk a bit about the rationale behind the decision to accelerate patients' access to medical records, and also what the coverage at the moment is in terms of this being implemented across England. And just to be clear, this is England specific at the moment. We will look at what some of the key concerns are, the key safeguarding issues relating to the introduction of patient access to medical records. And we will cover what IRISi have been doing over the years to help address these potential risks. And then we will have that good amount of time, as I said, at the end for questions and also discussion on this. Okay, next slide, please, Mel. So, IRISi, who are we and what do we do? We are a not-for-profit social enterprise established to improve the healthcare response to gender-based violence. Our vision is a world in which gender-based violence is consistently recognised and addressed as a health issue. And our mission is to improve the healthcare response to gender-based violence through health and specialist services working together. Next slide, please, Mel. Most of you will probably be familiar with the IRIS programme. IRIS is our flagship programme. It is a general practice specialist domestic abuse training and referral programme. And the IRIS programme teaches clinicians in general practice to recognise, ask, respond, refer and record. Now, that recording part is the key part here in today's Lunch and Learn session. For about the past 8 years now, we've been aware of discussions about increasing patient access to medical records. And over that time, through the IRIS programme, we've been training general practice staff. And part of that training covers recording disclosures of domestic abuse in the patient's medical record in a way that is safe and making sure that record is safe by hiding that information using an online visibility function. And this is in line with the RCGP guidance, Royal College of General Practitioners guidance on recording disclosures. And these changes don't change the fact that it's really important that clinicians continue to record disclosures of abuse, and particularly in relation to coercion and control, and that they also consider the wider family and link children connected with the person who's made that disclosure, as of course children are recognised as domestic abuse victims in their own right. So the IRIS programme has been responding to some of the issues and concerns around recording since its inception. So this is still the biggest part of our work. However, just coming back to this kind of brief summary of what we do, we are wider than just the IRIS programme now. So if we could move on to the next slide, thanks, Mel. So the ADVISE programme is our second commissionable intervention, and it very much follows the same kind of format as the IRIS programme and was adapted from the IRIS programme to reach more diverse and hard to reach populations who might not access their GP, who do access their sexual health service. So ADVISE is an adapted version of IRIS for sexual health settings and follows the same kind of pattern of providing in-house specialist training on domestic abuse and also sexual violence, and providing a direct referral pathway for patients affected by violence and abuse to a named contact, the advocate educator. So although this session is specifically concerned with changes that are coming, that have come in general practice recording, we do think this is relevant as well for our ADVISE advocate educators in the network. You will be supporting patients who, as well as having that contact with sexual health settings are, of course, also patients in general practices. So the risks and the concerns and the need to be aware of hiding information from online, being visible online, are relevant here as well. Having said that, I do just want to make clear, as those of you working for the IRISi programme will already know, those sexual health service records use a different recording system and are covered by different laws and guidance. So what we're going to be talking about today, this is specifically focused on general practice patients' medical records. Okay, and over to you, Mel.
Thank you, Lucy. So as Lucy said, we'll start the conversation by just thinking a little bit about why this accelerated access has happened within general practice. This isn't the focus of our session today, but I'm sure there might be quite a few of you that are sat there thinking, well, you know, why is this happening in the first place? And that might be a question or kind of a discussion that's happening locally. As Lucy said, we have been aware of the likely changes for a number of years. There's been many different kind of debates and conversations that have happened. We did speak to NHS Digital, I want to say maybe 3, possibly 4 years ago now, and had some conversations about, you know, how do we make this safe? And actually, you know, it's a big concern for all of us. And I'm sure as it is for many of you within the network or working within general practice yourself. But the decision has been made, and NHSE have made the decision in mind that it would be of great benefit for a kind of a large part of the patient population to be able to access their records online. You can see some of the reasoning here on the slide. So thinking about the ability to self-care, particularly for patients with chronic health conditions, making access to their GP, their medication, their prescriptions a little bit easier and a little bit quicker, so they may not have to wait as long. They kind of might not need to contact surgery for things like test results or referral notifications. So kind of, again, making access a bit quicker and easier for patients, but also increasing capacity on those general practice teams. Improving quality data and recording, and keeping in mind some of those principles around GDPR and data protection. NHSE are aware of, will come on, as Lucy said, to talk about some of the safeguarding concerns that go alongside this. And I'm sure a lot that have been running through your mind. But they have spoken to over 50 different charities when they were kind of completing this work, thinking specifically about health conditions, and have provided guidance for patients about the app. So there's a link that either Sarah or Lucy, you'll be able to pop into the chat now. And that gives some guidance for patients themselves about how they, you know, get the NHS app and how that kind of function works, you know, the identity checking through it, etc. But of course, this kind of does pose some risks to our more vulnerable patient population groups. And we'll come on to that in a moment. So what kind of is the overview in NHSE? So NHS in England, as Lucy said, this is where we're talking to and where this applies to at the moment. So all GP surgeries have been required via contract to give all patients in England online access, which is essentially access to their health record. This means that patients' online accounts through the kind of most likely scenario is their NHS app. And that means that they will be able to read new entries, including free text alongside appointments to their health record. And this applies to prospective record entries. So that means everything from the 1st of November moving forward. That is of last year, 2023. Historic data in terms of free text is not available. And we'll come on to some of those changes in a moment. The initial deadline for this was the 1st of November in 2022, but there was quite a lot of concern, particularly from clinicians themselves, actually, and quite a bit of pushback about this and kind of not feeling ready for those changes to come into place. So that was delayed until 1st of November 2023, which is when all of these changes have come into place. The information you've got on your slide in front of you is taken from data from NHSE themselves, and it gives you a bit of an overview of where the access is at the moment. So over 1.9 million patients have got online accounts with full access to their new records. There is more than 1,800 practices that now are offering full prospective record access by default, which is now what they're contractually obliged to work towards and to implement. And over 200 million views of patient information through the NHS app since its launch in December 18. We'll come on in the next slide to kind of what has changed and the difference between that December 18 and November last year. And yeah, as you can see, and I've already mentioned in that bottom point, the updated GP contracts requires that this new health information is available to all patients, and that's unless they've kind of opted out or there's exceptions that apply. And I'll come on in a few slides when we talk about how that blocking access works and what patients and clinicians can do safety-wise in these few cases that the NHSE is saying we've got kind of vulnerable individuals we're recognising. So let's come on to think then about what has changed and what has not. So as you would have seen on that last slide, the NHS app launched actually quite a few years ago, so back in 2018. So it isn't kind of new on the field. The main difference in what has changed is that patients historically, prior to this accelerated access, would still have been able to access their record online. There's a varying degree in terms of, it depends how long you've been at the surgery that you're at, and not all areas transfer information over kind of where you've moved around. So for example, if I use myself, my not particularly too glamorous self has been in Bristol since I was born. And so when I go into my NHS app prior to the accelerated access in November last year, I could actually see all things that I had been prescribed by my GPs in Bristol, kind of going all the way back to when I was little and having, like Calpol prescribed or like things like that. So I could see all of my prescriptions, not necessarily appointment dates, and certainly not any detail in there that the GP had recorded about my health information. But prior to last year, patients have been able to have access to their medical record. The main thing that has changed is that from the 1st of November last year, practices should be implementing automated access to records. So it's no longer a kind of practice by practice decision of we want to give access or we don't want to give access. The guidance under these contracts is that automated access should be given unless for any reason it needs to be restricted. And again, we'll come on to that in a moment. And it's access to prospective consultation notes. So any consultations from the 1st of November last year, you should now be able to see not only what you were prescribed or the appointment that you attended, but what that clinician has noted down in your medical record as a result as well. So what we're talking about is all of that extra information, not just prescribed paracetamol or, it kind of detail that goes underneath that as well. And again, that's prospective. So it's not going back historic. It's just any appointments from the 1st of November next year. Last year, sorry. What has not changed is still the guidance for those that are aged under 16 years. So that kind of bulk enablement functionality doesn't change access for 16 and under, and that leaves it as a local clinical decision. There is some guidance from the RCGP, which is the Royal College of General Practitioners. Sarah or Lucy can pop that link into the chat now. But essentially that still is kind of given on a practice decision of are we sharing this information or are we not, and thinking about redacting that information if we think it's anyone at risk. So this brings us on to that kind of access by third parties has the same proxy consent processes and procedures. So what we're thinking about here is in a domestic abuse situation, let's say, is the abusing parent, biological parent of child, or has parental rights over child, and therefore has the ability to request that child's medical record, and there's details of domestic abuse. It's those same procedures and processes that have always been in place. So thinking about a redaction protocol and that any reference to information that could put anybody at risk. And if in this situation, we're obviously thinking specifically disclosures about domestic abuse and sexual violence, then those disclosures would be blotted out and would be redacted. So those things are still the same as they have always been. And also unauthorized access by health professional. So again, those regulations really should be in place about what health professionals are accessing medical records, and it should only be health professionals that are actively involved in the healthcare support of that patient. So all of those sort of things have not changed. They remain the same as they were before. And of course, I'm sure this is the thing that is on people's minds the most for those of you that are attending today, is what are the potential safeguarding risks? And I'm sure our mind is kind of spinning with all of the potential possibilities, as has ours as an organisation, like I said, for many years. And when we had conversations with NHS Digital about, how do we make an app safe for those that might be being coerced, our kind of pushback and response at the time was that there isn't really a way to do that. There isn't really a way to make it safe. What we do know is that perpetrators may become aware of this tool and use it to further control and coerce patients. We know in cases where there is extreme levels of coercion, that perpetrator may be forcing the patient to download the app, to log in and provide passwords to the app, and then viewing the information that sits within there. So kind of getting access to any sensitive information that isn't hidden from online visibility for that patient. We also know that might include third-party information. So that might include letters from MARAC, domestic abuse services, the police. And again, if those haven't been hidden from online visibility correctly, that perpetrator may well get access to all that information. We also know that some of those pros that we mentioned that might be the case for the majority certainly can be cons. So for example, we talked about the ability for patients to be able to book and cancel appointments through the app, control their medication and prescriptions, and onward see what's happening with onward referrals. Of course, in a perpetrator's hands, we know that where somebody is being highly coerced and controlled, that's going to have a really negative and risk impact. So perpetrators cancelling appointments for clients, cancelling access to medication. We know that also that may be used to track and control movements and whereabouts. So, for example, we might have patients that have moved to a refuge and registered at a new GP out of area, booked an appointment there. And if the perpetrator is accessing that app, we'll be able to see where that appointment has been booked and potentially kind of track that victim or survivor. And we know that there have been examples already cropping up of where this is happening. So, of course, this holds a huge concern for those of us that are working with victims and survivors. And there are really kind of big risks involved. We'll come on to talk about what we are thinking, what we're doing about that and the conversations we're having. We also know some of the risk related to this could be that clinicians are not aware of how to hide from online visibility. This has been a big concern from ours at IRISi for many years now, actually. We kind of knew this was likely to happen. And a lot of the time when we were training about hiding from online visibility, clinicians were saying, we don't know how to do that. We don't know where that is. We've never heard of this before. And that obviously was quite a big concern that prospective access could come in at some point. And we didn't know at the time, how much that would show and how much it wouldn't. So it also gives concern about perhaps clinicians not being aware of what needs to be hidden and what doesn't. So we're not just talking about overt disclosures of domestic abuse here, but again, that third-party information that we could be receiving from MARAC, from police, from other professionals. or things to do with sexual and reproductive health that, again, is not necessarily linked to sexual health clinics, but there still could be sexual and reproductive health that crops up in general practice that, again, that needs to be hidden, because, you know, although there's not an overt disclosure of domestic abuse, a patient may not want the partner knowing that they're accessing, you know, the pill or having the coil fitted or any of those sort of things. So that could also increase risk as well. So what are we doing? Kind of what are the steps that are being put into place? As Lucy has mentioned, and I've mentioned many times now, we've been concerned about it for a while. Within IRIS general practices and IRIS training, we have been talking about hiding from online visibility access. I want to say, Lucy, I don't know if you would have a better guess than me, but I'm going to say at least 8 years, potentially longer.
As long as I have worked for IRISi, which is going back to 2017 when IRISi started, there has been coverage in the training on how to safely record disclosures of domestic abuse, including hiding those disclosures from being visible if a patient's accessing their records online. So from at least then, quite possibly going back before, it's just my memory is a bit hazy, going back before then.
Thanks, Lucy. Yeah, so for quite some time, we have been really harping on about any disclosure of domestic abuse or anything related to domestic abuse that could put a victim or survivor at risk if a perpetrator were to see it should be hidden from online visibility. And what hiding from online visibility does is it means it doesn't show up in that NHS app. It doesn't show up in that record. So from 1st of November onwards, if someone is seen discloses about domestic abuse, it's hidden from online visibility. Those notes are not going to show up in that NHS app. And so that patient is kind of protected from anyone else who's accessing that record, seeing that information. So we've been doing that for many, many years with IRIS practices. Of course, that is a small percentage of the national kind of general practice coverage. But nonetheless, we've been doing that for some time. We have updated our training materials that are due to be released next week, actually, and there is a little bit further information in there about the increased level of access now, again, hiding online visibility, but also thinking about restricted access. So I'll come on to that in that next slide, but there is something that practices can do to restrict access entirely from that NHS app. So not just hiding a consultation, but restricting access as a whole. And our approach really at IRISi has been about supporting and increasing clinician awareness about these risks and how to address them. There are steps that we'll talk about in the next slide that patients can do to protect themselves, but we really are trying to say if clinicians are aware of how to record safely and properly in the first place, this doesn't need to become a risk or a responsibility for patients to have to protect themselves. But as long as clinicians understand how to record properly and safely, we can kind of mitigate that risk from the get-go. We've also tried to be quite careful about public-facing messaging. So we have released some guidance. You'll see the link there on our website, and Lucy or Sarah can pop it in the chat now. But there's obviously a fine balance with anything public, isn't there, to do with domestic abuse, that the more we publicise it to make patients aware, the more perpetrators will also become aware that there is now increased access. And this is another thing that they can use as a tool to control and track their partners or family members that they're perpetrating abuse against. So we've tried to kind of strike a little bit of a balance and be mindful of that. The other thing that we're doing alongside Women's Aid and quite a few other organisations now that have joined is being an active part of NHS England's Safeguarding Reference Group. That safeguarding reference group happens regularly. We sit within those meetings, and it has been looking at the potential issues that can crop up for victims and survivors and those that are kind of vulnerable, but also thinking about the measures that can be put in place to try and reduce those risks and manage those risks. And that does include a reporting mechanism for the adverse effects, which can then be responded to in real time. What I would say is if you are having any kind of cases where the NHS app has been used to control and perpetrate abuse, and where significant risk has been at play, please do let us know about those situations with people that you're supporting, because we can feed those situations back into this safeguarding reference group, share that information, feedback to NHSE, and also try to think of, if there are any further ways to kind of mitigate those risks. So do share those if you have them. And yeah, we've worked with NHSE on the wording of their safety notices, and kind of, the access to the system. And I mean, to a degree, there's not a way to make that completely safe. There never is, but we've been part of those conversations. There's also another link that we can pop into the chat as well, which is the Royal College of General Practitioners, RCGP, in collaboration with NHSE. They have developed a guidance and resources toolkit for practices to help them with recording, safely and securely. And it gives kind of clinical examples of how GP online services can empower patients to have kind of that greater control over their health conditions, but also a little bit of a look about how that app functions and what the GP responsibilities are. So what are the common questions that crop up? And this is the last kind of bit from me, and then we will leave space for kind of questions and discussion to come from this too. How do we stop a patient from accessing their medical record if we have concerns? So clinicians can block automated access. So it can be done at practice level. It's using a SNOMED code, SNOMED code 104, which is enhanced review indicated before granting access to your own health record. And that code goes into the system like any other code would. To remove that code, it requires practice level sign off. And so it does give the patient some protection from the kind of perpetrator accessing information. That code can also be added where a patient says, I don't want this automated access. I don't want this to be in my NHS app. And therefore you can apply that 104 SNOMED code that will block that access within the app. Now, clearly, there are still other risks that sit within this. So it could be that the perpetrator has found out about the app, accesses it, and sees that it has been limited and it has been blocked, and then starts to question as to why, of that victim survivor of that practice. So again, it's not necessarily a fail-safe, but at least it does hide all of that information. We can also encourage patients to remove the NHS app from their phone altogether. So just make sure that it has been deleted, it has not been downloaded. And now, of course, again, if the perpetrator is already aware about the app, we do know that asking them to delete it is not necessarily going to be a fail-safe. That perpetrator could force the patient to re-download it, could push them and ask why they've deleted it and make assumption that they're hiding information. And so we know that that also might not always be an option available to patients. But those are a couple of things. So blocking 104 SNOMED access at practice level, patients can ask to do that. So those of you that are advocates, it's worth having this conversation with victims and survivors that you're supporting. And if the perpetrator isn't aware of the app already, then certainly we would suggest removing that app from their phone, and potentially going to the practice and requesting that the 104 code is added and it is blocked, so that it's mitigating that risk kind of from the get-go. The main thing though, really, and I think the safest thing of all, particularly if a perpetrator is already aware about this, is about clinicians hiding everything from online visibility. It means that the app is still there. It means that perpetrators, if they're going to access it to coerce and control, can, but any information about domestic abuse disclosures, sexual and reproductive health that could increase risk if the perpetrator knows it are just simply hidden, and they're not available for view. They're not there. Other questions maybe, what do I do if a patient discloses abuse and I want to record it safely? I've kind of just given that anyway, but it is hiding from online visibility. our guidance at IRISi is always, if in doubt, document and block it out. So if in doubt, document it, because it's really important to record disclosures of domestic abuse for many, many reasons. So we want to make sure we're documenting it, but then we want to block it out. We want to hide from online visibility and make sure that it doesn't come up on that system at all. Each system is slightly different, so we haven't given like a specific way for this, but I know there's a lot of clinical leads in areas, and we will certainly be able to connect and give a little bit of guidance if you're not sure how that works in your area. But we'll have people that are on EMIS, System 1, Vision perhaps, so it might look slightly different in each area. In most, it should be quite simple. It should be simply that you can click on the consultation itself that you've entered. There should be a list that comes up, and there should be a button that says hide from online visibility or hide from online access, something kind of along those wording. We also need to make sure that we're hiding from online access. Lucy talked earlier about that think family. So not just for the victim or survivor that has come through, but are there children or vulnerable adults connected to that we also need to make sure their medical record is either being redacted if requested, or anything on theirs is also being hidden from online access if that parent or carer has the right to access the NHS app or is kind of at risk of controlling and accessing the app. And this leads us into perhaps, the father or that kind of abusive parent or family member or carer wants to access the victim or survivor or children's record where the mother has been abused, and so it's recorded in the child's record also. What do we do? This is the same as I mentioned earlier, the same as it has always been for children and vulnerable adults, where family members, parental figures, carers have the right to access the record. We just want to make sure that we're redacting it. So we're having a really good redaction protocol in place so that it is blotted out if requested. And of course, like I just said with the previous point, hide from online visibility in any circumstance where you think someone else seeing this information could put the patient at risk. I think that's everything to say on that note. I can see the chat has kind of been pinging off a bit here, there, and everywhere. So what I might do is actually come out of screen so that I can see everybody. We'll share our final slides as we wrap up at the end, but I'll come out. And Sarah or Lucy, if there's any questions we want to call out that have already gone into the chat. If not, if there's questions that people have now that they would like to put into the chat, kind of any concerns that you would like to raise in this session, we've got a good 20 minutes or so before we're due to wrap up, so plenty of space if anyone wants to. You're welcome to unmute also if you would like to, but please keep yourself muted if you don't have a question.
There's just one question in the chat from Holly. So saying, myself and a colleague attended a practice recently who said if their NHS details are hidden by a practice, this is not forwarded on if the patient then moves to a different practice. Do you have any more information on this? They said that we can inform the surgeries if we know patients move, but there's always a chance we may not be aware.
Yeah, absolutely. So, Holly, let me just reread that. You mean if the details are hidden by a practice in that area and then the patient moves to another practice, does it remain hidden or does it not? I'm not actually entirely sure of the answer to that myself, Holly, and there might be a few that I'm not able to answer, but certainly that will bring back to the safeguarding reference group. And we'll do a readout afterwards as well, so that everyone who's attended this has got some of those questions and some of the answers. I'm not entirely sure from area to area if they have to, my understanding would be because it's a practice-based level code that they put in, if they move area to a new practice, I think that code would probably have to be added to that kind of new record in the new practice as well. I know we do have a few clinical leads on the call, so I don't know if anyone has got, greater knowledge than me in that practice kind of setting that wants to answer or add. Claire, yes.
Hiya, can you hear me all right? Did you get the chance to test my microphone before joining? So yeah, I'm a GP based in central Manchester. So on that question of what happens when a patient moves GP, they would automatically have online access again. unless it's already been blocked with that blocking code, that they need review before having access to their online record. Given that risk is dynamic and these things can change over time, it's not really safe to rely only on that, because that's just one thing done at one point in time and stuff can change subsequently. So I suppose it's the responsibility, and I suppose all GP surgeons have had to kind of risk assess how they assess the new record of new patients. So in England, it's done by electronic record transfer. It's meant to occur within a 2-week period of time. So, you change GP surgeries, within 2 weeks, your entire electronic GP record has gone from surgery 1 to surgery 2. Often it doesn't work out that way, and the record looks pretty blank. And as a new GP, you have to fill in the gaps and the details. So that's a potentially risky time. The kind of failure or not having a process for the admin team to go through the new record when it does download is a potential risk as well. So but the thing is that all different GP surgeries have had to generate their own personal approach to this. They have to risk assess and devise a way so that their admin team looks through any new record that comes from NHS spine, like the GP to GP electronic record. They look at it and see, is there anything in that, in the problems codes, that looks alarming or concerning? So we'll be looking for safeguarding codes, 14XD codes, so history of domestic violence or domestic abuse, or that kind of enhanced review is indicated code. So I suppose it relies on the GP surgery having a robust process in place.
Yeah.
But again, that's fragmented, and it's kind of up to each individual GP surgery how they do it.
Yeah. Thank you so much, Claire. That's a really helpful response.
Okay.
I can see, Katrina, you popped in about it only happening in England. Yes, you're correct. It is only NHS England that is implementing this at the moment. My understanding from the Welsh sites that I have spoken with is it doesn't appear there are any immediate plans to implement this in Wales also. So kind of on the horizon, no immediate plans. Whether or not that changes in the future, I don't know. But at the moment, just England and no plans in Wales. I'm not sure about Northern Ireland and Jersey, where I know we have sites also. Lucy.
Can I just come in on the Wales question? I'm just passing on here what I have heard one of the Welsh clinical leads say when we were having a discussion around patient records, and that was that her sense is that Wales are watching and waiting and seeing how this pans out in England, but that the long-term likelihood will be that Wales will follow suit. At what point in time, I don't know, but that will be the likely direction of travel in the kind of medium to long term.
Thanks, Lucy.
I have a question, actually. I'm a little bit hazy around what happens with accessing records if the perpetrator is a GP. This has come up several times with myself, some of my cases, and it's been a massive cause of concern for the service user. And I'm still a little hazy around what the processes are.
Yeah. Good question, Rachel, and this comes up a lot actually, particularly in our training sessions with people in the network like yourselves that are delivering frontline. So there's a couple of things that we have advised within IRIS training, which is one, NHS Digital provide a patient opt-out form, and a patient opt-out form means that in those instances where the patient is thinking, partner is a GP in another practice or perhaps even in another area and is concerned that they can opt out from their medical record being shared. And that has its cons because it means that anything that is in that GP record isn't being shared with other health professionals. So it does limit kind of patient care from that angle, but it does mean that it is more restricted. The other thing we were told from, and there is actually some guidance, I think it's in one of the links that I gave Sarah and Lucy to put out, but I will double check, Rachel and Sarah, if you can make a note for me to add it into the readout. RCGP have put something in about health professionals accessing records. Our conversations from NHS Digital are that they very much assure that healthcare professionals should not be accessing any patient's record where they are not providing or involved in direct care for that patient. And if someone were to repeatedly access a record, particularly for someone who is in their family kind of community or a partner, that would be captured, and it would have quite severe disciplinary responses.
So every single time any staff member goes in any patient notes, it's the system records records the date, the time, your identity. So unless you used somebody else's login card and did it would be related to the smart card that you had in the system. It would show up as that person. But that can be audited. So for example, our surgery, we are able to, so it's the deputy practice manager who would audit that kind of situation, who'd be able to go through the notes and see who'd been in the notes. So for example, I guess you could tailor it to what you needed, but for example, you could, and the patient could request could ask, has this person accessed my notes? And then they'd be able to see it. I mean, also, if you are trying to access the notes of an inactive patient, i.e. a patient who's not registered at your GP surgery, or someone who's recently left your GP surgery, you have to enter give a free text documentation of why you want to go in the notes. And that, again, that's an audited thing as well. So if there's anything that looks untoward in terms of the way the notes have been accessed, that can be seen as visible. Also, staff can run periodic searches. So if we were in a situation where we ran a weekly search to check who had been in the patient's notes for safeguarding reasons. So yeah, it can be checked. There's no automated search or kind of standard process for it, but it's easy to tailor an in-house one, I suppose.
Thank you. That's really helpful. Thanks a lot.
So just some of those next steps, I guess, to capture what it is that we will be doing and still are doing. So we've talked about those updated training materials to provide additional information. Those are for areas that have an IRIS program implemented. If you have joined us and you're from an area that doesn't have IRIS and you want to find out more about how to get IRIS in your area, Sarah, if you could pop my email into the chat box, I'm more than happy for you to send me a direct email and we can have a little bit of a conversation about that. IRIS is going to continue to train IRISi actually. IRISi will continue to train IRIS and advise advocate educators so that they can work with patients safely to address any concerns about their GP medical record. Hopefully this session has been of use. We may run a couple more of these in the future, but this has been recorded and we'll share that also. In any GP practices that we train, so any areas that are getting IRIS, those of you on the call that are advocate educators and clinical leads delivering that training, we are going to be training those clinical and those reception staff also about how to safely record on the medical record, particularly that information from third parties and how to keep those non-direct disclosures, but information that can still be risky, how to hide that from online visibility and how to manage that safely. Our training includes information for clinicians to report any adverse effects through to their safeguarding leads, and that feeds into local safeguarding groups who can monitor those changes and feed that back into NHSE. And again, that safeguarding reference group, we're an active part of that. So you can feed those potential risks back into us and we can make sure that that is shared and flagged. That is it for our session together. So yeah, that's our kind of general info app, but you've got my email in the chat box as well. If there's anything that you want to follow up and flag, any questions you popped into your mind 5 minutes after you got off the meeting, then please do feel like you can get in contact and send those through. Yeah, we're kind of here to help and support with that. There's our IRISi website as well, in case you want a little bit more about us and the work we do if you're not from one of our IRIS areas.